A 22-year-old female presented with visual field defects. I am showing you a composite of T1 weighted axial thin section, T2 weighted axial orbits, and axial or coronal T2 weighted brain MRI scans. Describe orbital and brain findings.
Right, so the orbital MR images demonstrate fusiform enlargement of the posterior aspect of the right optic nerve, which extends posteriorly to involve the optic chiasm. The coronal scan confirms significant bilateral thickening of the posterior segments of both optic nerves. On the brain flare and T2 weighted images, there is a round focus of hyperintensity in the right cerebellar hemisphere. A second hyperintense lesion is identified in the posterior right midbrain, causing slight convexity of the right cerebral peduncle. There is no surrounding vasogenic edema or mass effect associated with these parenchymal lesions.
What is the diagnosis? What is the differential diagnosis for optic nerve thickening?
The diagnosis is an optic chiasm and bilateral optic nerve glioma in the setting of neurofibromatosis type 1. The main differential diagnosis for optic nerve thickening is an optic nerve sheath meningioma. Other differentials include sarcoidosis, multiple sclerosis plaques, lymphoma, leukemia, metastases, and intracranial hypertension, enlarging the perineural CSF space.
How do you radiologically differentiate optic nerve glioma from meningioma?
Optic nerve gliomas typically present in childhood, show a buckled or tortuous nerve, and calcification is rare. On the other hand, optic nerve sheath meningiomas occur in middle-aged women, show calcification in up to 50% of cases, and keep the nerve straight. Meningiomas also demonstrate the classic tram track enhancement pattern on axial contrast scans and a donut sign on coronal views. Additionally, meningiomas present early with progressive visual loss due to direct nerve compression.
Explain the diagnostic criteria for neurofibromatosis type 1 and the nature of the coexisting brain lesions.
To diagnose neurofibromatosis type 1, a patient must meet 2 or more of the classic criteria. These include 6 or more cafe-au-lait spots, axillary or inguinal freckling, 2 or more Lisch nodules, 2 or more neurofibromas, optic glioma, bone dysplasia, and a first-degree relative with the condition. The hyperintense cerebellar and brainstem lesions are hamartomas, also known as myelin vacuolation or focal areas of signal intensity. These benign lesions are characteristic of neurofibromatosis type 1 and typically decrease in size or resolve as the patient reaches adulthood.
What complications can occur, and how would you manage this patient as a radiologist?
Complications include progressive visual field deficits, blindness, and development of malignant astrocytomas in the cerebrum or brainstem. As a radiologist, I would recommend a baseline post-contrast brain and orbits MRI with thin-section fat-suppressed sequences to evaluate enhancement. If any hamartoma shows interval expansion, mass effect, or enhancement, I would suspect malignant conversion to an astrocytoma. I would also recommend checkups for cutaneous neurofibromas, Lisch nodules, and refer the patient to ophthalmology and neuro-oncology for vision-preserving therapies.